Welcome, everyone, to Medications for Opioid Use Disorder with Dr. Robert Joel Bush. Let me introduce Dr. Bush to you. He began his interest in addiction treatment during his United States Army career as a physician resident training in family medicine. His passion for treating patients with addiction continued to grow as he completed a fellowship in addiction medicine at the University of Maryland in Baltimore, and then began treating soldiers and their family members who suffer from addiction. He completed his 15 years of active duty service in 2018 and transitioned to the Utah Army National Guard, where he now reviews drug tests for all soldiers in the state of Utah as part of their substance use prevention effort. Currently, he works at Wasatch Behavioral Health in their substance use disorder division programs, where he treats patients with medications for their substance abuse and substance use disorders. He prefers a direct relationship with each of his patients, helping those who struggle with any addiction, including heroin or other opiates, cocaine, alcohol, marijuana, or any other substance use program or problem. Dr. Bush, we're honored to have you with us, and we turn the time over to you now.
Thank you so much, Tony. It's definitely a pleasure to be able to participate in this wonderful conference. We have a really awesome topic today. It's medications for opiate use disorder, something that I'm very passionate talking about, and it is also a very hot and debated topic, especially in rural areas. So let's go ahead and get started and we'll talk about it. We're going to talk about medications for opiate addiction today. Sometimes when I talk to people about this topic, I will ask them when they think the opiate epidemic in our nation started. And, a lot of different answers will come, maybe in the 1990s or in the early 2000s. But in reality, it goes back much further than that. So where opiates were introduced into the culture of recreational use or medicinal use dates back way back to where we have our earliest records on clay tablets, earlier than 3000 BC. We also have records of opium being used by the ancient civilizations in Greece, China, India, and in Rome, as well as the Arab communities. In the Middle Ages and the Renaissance, records kind of did discuss opium use as well. And then in 1775, the year before our country became an official nation, opium first started arriving in our country. The opiate epidemic, though, didn't really start until almost 100 years later. Now, in 1805, in Germany, a scientist named Sertner figured out how to isolate morphine from the opium that comes from the poppy seed plant, the poppy plant. And he was able to figure that out. In 1850, somebody invented a thing called a syringe, a hypodermic syringe. And those two events kind of prepped us for the ability to use intravenous opiates for the first time in our world, in the global sense. In 1861 through 1865, we had the Civil War in the United States, which is a particularly bloody war with a lot of amputations. Amputation was also recently discovered as a viable option to save a limb and to save an individual on these close-range battlefield wounds. And so amputation was a big, it kind of got popular among medical treatment facilities with battlefield casualties. So you have this kind of perfect storm between morphine being invented, the invention of the hypodermic syringe, and then the Civil War. And it created this perfect storm of people being administered a lot of morphine through a needle into their veins directly, which has a very different effect on someone than when you give them a parenteral or orally administered morphine. So that's really where the epidemic started. It was right after the Civil War in the 1860s through the 1920s. We started seeing this new phenomenon happen where people were becoming addicted to this stuff in large quantities, and it had a really devastating effect on families and individuals and in communities. And so that's where we first started seeing this epidemic kind of manifest itself. Now, in 1898, something happened that changed the face of the world forever, and that was that this pharmaceutical company named Bayer began to market a new drug called heroin. It was a cough suppressant, and heroin was its trade name. 6-monoacetylmorphine is the actual name for it. And it became, it kind of became a new thing. It was, of course, marketed as a cough suppressant. However, how long do you think it took for all of these folks who we often call opium slaves that, were injured in the Civil War, were able to catch on really quickly to the fact that heroin, parenterally administered or IV, was better than regular morphine. It is more potent, and so back then you could access any kind of at any kind of place. You could access the heroin from a pharmaceutical supply chain on like a wagon pulled carriage, or you can access it at an apothecary or a drugstore, or even your regular town store. No prescription was needed at that point. 1906 was a reaction to this problem, in that a lot of the products that were being sold started to include heroin and morphine in their in their line of products. So a lot of companies were doing this, and then you had kind of that whole snake oil era of people saying, hey, this is this Dr. Bush's tonic that will cure the ague and the rheumatism and all kinds of things. And they would often include heroin, or they would include morphine in those, included with alcohol or some other thing. So in 1906, the Congress they decided we need to do something about this, because a lot of these folks were not labeling these things honestly, which is not a surprise. But they basically decided they needed a law that said whatever you have in that bottle or in that pill or in that package or powder has to be labeled correctly, and we will punish you if you don't tell the truth. In 1914, another law was passed, which was in response to the growing epidemic of people using heroin and other opiates. And we had a lot of well-meaning doctors who decided that one of the possible ways to treat this would be to actually administer some opiates to people in a very controlled fashion. Like, if you come to me, I'll give you a prescription, and then, it'll help you not go into using stuff that you shouldn't be using. So in 1914, the Harrison Narcotic Act was proposed, which basically said any physician who was prescribing an opiate to someone they knew had an opiate addiction would be punished as a felon. And so from 1914 to about 19, which is when the law, I think, went into actual action, you had a lot of doctors that started to get prosecuted for this. And a lot of these physicians ended up in jail or prison. And so that kind of caused a reaction in the medical community that we felt, we as a medical community felt we can't do that because we don't want to get in trouble. So we did a lot of hands off, a kind of a knee-jerk response, but basically hands off. We're not going to prescribe opiates to anyone for any reason. And so you kind of went into this era of sort of no opiates were being prescribed. And that sounds great, except that there is always an equal and opposite reaction to whatever you do. And we've noticed that, and we keep learning that. Unfortunately, because opiate prescriptions were at an all-time low between the 20s and the 50s, that is when the illicit supply of heroin started to grow for the very first time, because heroin was being provided through legitimate channels or through, pharmacies and drugstores up until that time. And as soon as all these doctors were punished, and the rest of the doctors started getting really hesitant to prescribe or approve any type of medicine that was an opiate product, you then have a commensurate rise in opiate abuse, illicit opiate abuse, and recreational opiate abuse. And that is what happened. So this is when heroin really sort of took off in the underground community, which was all through the 20s, 30s, 40s, and 50s. And it kind of culminated in the 60s, where it just became super problematic in the United States. And you can see kind of some of these other bullet points. There's the others opiates that are getting approved through the FDA. Well, actually, the FDA was created during that time. The Vietnam War happened, and as you're starting to see, a lot of these wars really played a huge factor. But the Vietnam War played a really huge factor for the opiate epidemic, because in Vietnam, heroin was both regular morphine, opium, and heroin were being produced in large quantities. And so we sent all of our service members, or our soldiers, over to Vietnam to fight in a thankless war. And they were both being killed in large numbers, and their home community, or the United States community, was not supportive of this war, or even of the soldiers that were fighting it. And so a lot of these soldiers were escaping into heroin use in order to kind of just get a break from all of that was going on around them and what they were hearing from home. It's kind of incredible, but 44% of the urine tests that were done on soldiers returning from Vietnam were positive for heroin. And that's a very, very large quantity of people. This is the first time that the United States started testing military service members for illicit drugs. Right around that same time, there have been a lot of people that were in the medical community that started to try to reawaken this idea of giving out some sort of medicine that was an opiate class to try to curb the use of the illicit opiates. And so a long-acting opiate called methadone was proposed that would be a good candidate for this treatment. And in 1960, the first methadone treatment program was established. The drug methadone was endorsed through these programs by the government as a testing program initially, and then it was approved as a viable treatment option. So from 1960 up until about 2000, the only drug that we had approved in our country for treatment of opiate use disorder was methadone. And it could only be administered in a very specific location, and it was only through those methadone treatment programs that were approved both by state and federal entities. The Substance Use Act was also passed and signed into law right around that same time, which meant that you scheduled these drugs into their categories of, like, the Controlled Substances Act, basically. Let's go to the next slide. Okay, in 1973, the DEA was established because the government needed some sort of enforcement agency to try to tamp down all the illicit use of these chemicals. And the follow-on from the reaction to the Vietnam War, which was the military basically took the approach of treating their soldiers instead of kicking them out. They said, we know that if we kick them out, that's not going to solve their problems. So what we're going to do is we're going to keep them as soldiers, and we're going to treat them for their opiate problems or their alcohol problems. The DEA being established, the controlled substance use being established, all of those things coming in right around that same time frame led to an era in our country of what we call opiophobia. In other words, the medical community and some of the lay community was afraid of opiates because a lot of family members saw what happened to the soldiers coming back from Vietnam. And a lot of the medical community noticed that the methadone clinics were actually working. And the war on drugs that started was actually effective in some cases at rooting out some of the illicit supply. So we had, for the first time ever, we had illicit supply decreasing, we had pharmaceutical supplies decreasing, and we had medications that were being prescribed for opiate use disorder decreasing through the clinics and the hospitals. So the doctors and all of the medical professionals started to say, maybe we shouldn't be prescribing opiates. Look at what's happened here. And so we went into this era where opiates were not prescribed anywhere nearly as often as you might think. In fact, in 1986, the World Health Organization recommended against opiates for chronic treatment unless you had no other option. Interestingly, all the while, you see all these other opiates being approved by the FDA for pharmaceutical purposes, like MS-Contin, OxyContin, and fentanyl. In 1992, the Substance Use Mental Health Services Association and the Center for Substance Abuse Treatment were created by Congress. And then in 1990s, you had this kind of era of like the baby boomers were getting older and they were having the normal aches and pains of life. But the differences between the silent generation and the baby boomer generation was that the baby boomer generation had this idea that was a little bit more common among them, that if I'm in pain, it's not a matter of me trying to get rid of my pain or suffer through my pain, but it's a matter of me needing to get some help. And a lot of the baby boomers' children were growing up in this era as well. And if any pain that they had, they also felt like, hey, this should be handled by someone. 1995, another thing happened that would forever change the face of the world. And it was that the company Purdue Pharma was able to get OxyContin approved in 1995 by the FDA. OxyContin was formulated specifically to try to reduce abuse potential of opiates. And that was their marketing ploy. Hey, this is a non-abusable opiate. You can't get addicted to it because you can't crush it and snort it. You can't inject it, which none of those things were actually true. But that was the marketing ploy. And in 1998, an example of what Purdue Pharma was trying to do was that they spent $207 million in 1 year on marketing for this drug. They wanted every home in America to have some OxyContin in that home. That was their goal. In order to achieve that goal, some very shady things happened between a company called the Joint Commission and Purdue Pharma in 2001. So leading up between 1995 and 2001, Purdue Pharma, the drug company, and the Joint Commission, which is basically the watchdog of all hospitals and medical facilities in the United States, they are the company that says, if you have to practice a certain way or we will shut you down. So the Joint Commission and Purdue Pharma, they entered a very secret deal between 1995 and 2001 that Purdue Pharma would produce all of this OxyContin and the Joint Commission would provide the opportunity and a pressure on the medical community to prescribe it. And so what happened is that the Joint Commission came up with this campaign called the Fifth Vital Sign. The fifth vital sign, so the vital signs are heart rate, blood pressure, oxygen status, and breathing rate. They said, we're going to add a fifth one, which is going to be pain. We're going to ask everybody about pain. And so the Joint Commission actually started requiring in 2001 that every treatment facility of any type of medical type, so outpatient clinics, hospitals, and surgical centers, every time they saw a patient at every single visit, they had to ask the question, what is your pain level? And so what this did was it accomplished the goal of getting OxyContin to be much more widely prescribed. And you can go ahead and just advance to the next slide, please. During this time, we also have an interesting side note, which is that the Drug Abuse Treatment Act of 2000 was passed, which allowed for prescription of buprenorphine to be given in a clinic. So remember the Harrison Narcotic Act that was passed in 1914 specifically made it illegal to prescribe an opiate to someone that you knew was addicted to an opioid in an outpatient clinic. So the only place they could get it was at a methadone clinic. But in 2000, the drug company Reckitt Benckiser, which marketed Suboxone, was able to achieve lobbying hard enough that in 2000 they passed a law saying if you prescribe the drug buprenorphine, and you can prescribe that in a clinic with certain specific regulations. You have to have an X number, which waives the Harrison Narcotic Act. And you can only have a certain number of patients each year, and you have to keep track of them, and the DEA will inspect you. And so that's how buprenorphine or Suboxone became a thing. And it was approved by the FDA in 2002. So during 2000 to 2010, this phenomenon called farming started to become popular. Farming happened as a result of overprescribing of opiates. So OxyContin was not the only opiate that was being prescribed in higher amounts, because every other opiate kind of rode the wave that OxyContin created. So between 2000 and 2010, opiate prescriptions by medical professionals increased logarithmically, like very, very, very high. And during that time, I went through medical school, and I can recall doing my anesthesia rotation. And I can recall a presentation by the company Purdue Pharma where they brought in their drug representatives to our catered lunch and told us, and I quote, "The problem in our country is not that we're prescribing too many opiates, is that we're not prescribing enough." And I'm quoting that because I remember how that seemed a little odd to me, given that I had a sister who grew up with an opiate addiction. So I kind of felt like that didn't make sense to me, because my sister was given excessive prescriptions of opiates from her doctor. But this is what they were saying, and they were getting their message loud and clear. In fact, all of the attendings that were in my medical school rotation were agreeing with these things. One of their taglines was, "Hey, if you prescribe opiates to patients, the vast majority of them never even use them. So we are so afraid of them abusing their opiates, but in reality, most of the people don't even use all of the stuff they're prescribed." That may be true, but farming that started becoming popular in the early 2000s was a very dark side to this. So if you prescribe excessive amounts of opiates to people and they do not use them, what happens to them? Farming was the practice where young individuals would go to their friend's house or to their family's house, and they would ask to use the bathroom. In doing so, they would look through their medicine cabinets and find opiates and use them, steal them. And so they call it farming. And it became very popular. And as prescriptions of opiates rise, so one thing that we've learned over the history of this epidemic is that if you cut off prescriptions of opiates, you will have an inverse response in increasing illicit opiate use in our nation. But the other thing that we learned is that as you prescribe more opiates and you overprescribe opiates, it also increases illicit use, because people will use the illicit stuff if they're getting used to using the regular stuff. So we have a two-edged problem. If we prescribe too much opiates, we get more heroin use that comes along with that. And if we stop prescribing opiates, we also get more heroin use. And that is basically the problem that we've been facing. In 2010, heroin became the leading drug of abuse because people started recognizing what was happening, and where many medical professionals started to dial back what they were doing. And in 2013 through 2015, infants born with neonatal abstinence syndrome, the number was over 27,000. And the overdose death from opiate grew to over 52,000. In 2016, another watershed moment happened when the Center for Disease Control came out with what's called their opiate prescribing guidelines. In those guidelines, they basically said, they focused very heavily on, are we doing the right thing by prescribing so many opiates? And they discovered, no, we are not doing the right thing. In fact, the data, the research data that supports opiate prescribing for chronic pain is basically lacking to the point where it shouldn't be done. In fact, there's a ton of evidence that showed that prescribing opiates for chronic pain was actually very dangerous because of how many people die from overdosing, whether intentional or not. So what happened because of that is that I remember this in 2016, that CDC guideline came out, which basically told the entire United States medical community that prescribing opiates for chronic pain was a bad idea. So what did the medical community do in response? They stopped prescribing so many opiates, which is, they were doing that incorrectly. But what did we just learn about when we abruptly stop prescribing opiates to people who have been on them for a long time and they are now dependent on them? They are going to go in bad withdrawals. One thing the CDC guidelines did not do was instruct well on how to deal with switching people from their opiate to another medication, tapering them carefully to avoid withdrawal, or switching them to a buprenorphine product to treat their withdrawal or their opiate dependence. Because of the Data Act of 2000 and Suboxone having a very high stigma of treatment for addiction, a lot of providers just cut their patients off of their opiates, but did not give them anything in the place of that. So we had a very rapid rise in heroin use because a lot of these people had nowhere else to go. In 2020, because of that increasing heroin use, COVID-19 hitting us right at that very vulnerable moment, and us reducing our prescriptions is why we are where we are today. In 2020, the overdose rate increased by over 38% from 2019. And in 2021, our preliminary data shows that the overdose rates from opiates in the United States was over 107,000. Just for some perspective, the number of people that die from car accidents in the country is less than 40,000. It's an epidemic that is increasing. Go ahead and go to the next slide. Because of fentanyl, and there's a whole other presentation that I'm going to be giving at the conference about fentanyl, but fentanyl is the new wave that is destroying lives even faster and more quickly, and is just burning through the community. And that is why we have this epidemic. So epidemic that started in the 1860s, we are still battling, and we've never been able to really get a full controlled hold on it. It would have happened in the 1980s if Purdue Pharma had not joined with the Joint Commission to create the fifth vital sign of pain. Let's talk a little bit about the diagnosis of opiate use disorder. The Diagnostic Statistic Manual of Mental Disorders, which is basically the psychiatry's Bible of mental health disorders, describes opiate use disorder as a disorder of impaired control, social impairment, risky use, and pharmacological dependence. As you can see, there are 11 different criteria that you need to meet, that you can meet in order to have this disorder. Using more than you mean to unsuccessful attempts at cutting down, craving opiates, using way more time than you should, revolving around this use. It results in a failure to fulfill some kind of obligation, whether it's at work, at school, or at home, and it creates social or interpersonal conflicts, reduced free time. It can often get you into hazardous situations, and physical or psychological harm, tolerance, and withdrawal. In order to be diagnosed with a substance use disorder of an opiate type, you need only 2 criteria out of these 11. The catch is the 2 criteria cannot be just the last 2, which are the pharmacological properties. If you only have tolerance and withdrawal, you cannot count that as an opiate use disorder. But you only need one of those plus one other in order to diagnose with a mild opiate use disorder. If you qualify for 4 of those, you'll have moderate, and anything 6 or above is considered severe. Next slide, please. So now that we know what opiate use disorder is not exactly the same thing as opiate addiction, although we tend to use those terms interchangeably. I would like to talk a little bit more about history. History is so important to all of this, and we've just gone over a ton of history about the actual opiate use in our country. But now let's talk about the history of the way we have approached addiction. For very, very many years, addiction was looked at as a moral failing. This is a person who just is a bad person. They have a bad character, they have no sense of right and wrong, or they don't care. And that is how it was treated for decades and decades and centuries, in fact. Phase two started in actually around the 1800s when Benjamin Rush, who was kind of considered the father of modern medicine, he suggested that addiction might actually be a disease. Once phase two got way underway, it actually transitioned it into being a mental illness instead of a disease. And phase three is treating addiction as a brain disease. So we're going to talk about each of these just briefly. Bonus points to anyone who can tell me who is the guy behind the bars. This is from a TV show that I watched when I was a little kid. It's called The Andy Griffith Show. And the Andy Griffith Show was about a sheriff in a rural town. And this character's name was Otis. Otis was the town drunk. And what they would do with Otis when he got drunk is, if he created any issues at all, which he usually did, is they would put him in jail. He would be in jail as he sobered up, and when he got done and he was completely sober, through his hangover, they would let him out of jail. He was a regular on the show, and he was a regular in the sheriff's office and in the jail. There were times when Otis would come in and he would put himself in he had like his own cell. This is a very good example, although it is caricaturized, of the way our global community has treated addiction for centuries. This person is a bad person, they need to be punished. Addiction is a thing that if you punish, it will go away. But as the show kind of hinted at, penalty for addiction by punishment did not solve the problem. Otis never got better. He just kept coming back every time he got drunk again, and he would get in jail. And there are millions of people who have suffered this never-ending cycle when they get into their addiction patterns. And we treat them as addicts that are moral failing addicts. So they just need to learn. If we punish them enough, they'll learn. This is often expressed as, if you just really wanted to change, you would change. The problem with this theory is that it's false. Addiction is not a simple moral failing or a simple choice, and punishment does not solve the problem. In fact, there's good data that says that the punishment often would exacerbate the problem, because one of the reasons behind people using substances like opiates is that there is a negative emotional state of some kind that they're trying to self-treat. So if we punish them, we are increasing their opportunity to need or to perceive the need for that substance. Next slide. As we tried to move out of that phase of treating people that had addiction as they were just bad people and started taking some of the blame off of them and putting them in another category, we found that a very convenient way of treating this was to talk about it as a mental illness. Bonus points to anyone who can tell me who this character is. And it is basically a clip or a picture from the movie One Flew Over the Cuckoo's Nest. That is Jack Nicholson in there. I think the character's name was Randy McMurphy. The things that they did for this character while he was in this insane asylum are documented in the movie. This is a fictionalized story, but it helps to portray some of the archaic ways we approach mental illness in the past. The problem with treating addiction like a mental illness isn't that it demoralizes the patient so much, although mental illness is stigmatized, but the problem is that it is an incorrect theory. Addiction isn't a mental illness like schizophrenia or depression or anxiety. Addiction is a brain disease. If you put someone in an insane asylum that has a brain disease, they don't get better. When you put someone who has an opiate or an alcohol problem into an insane asylum and they sober up, quote unquote, they would look very normal. So most of the insane asylums or the sanitariums would say, this person doesn't have any mental illness, and they would discharge them. And then the patient would go back to using. So again, a very heavy cycle of, repeated use and relapse. Next slide, please. What we really need to do is recognize that the science has discovered that addiction is not a mental disorder or a moral failing, it is a brain disease. It's easy to say that, but we need to know where in the brain this disease actually occurs. Addiction occurs in several areas of the brain that deal with reward and priority. The nucleus accumbens, which is sort of on the left-hand side of the screen, as a little yellow sort of blob, is our pleasure center. The nucleus accumbens is where, when you do something pleasurable, like eating your favorite food or having sex or connecting with someone in a really meaningful relationship, you get a surge of pleasure. And the nucleus accumbens is distorted or corrupted within this brain disease. The nucleus accumbens has connections with many other parts of the brain, including memory, emotion, and physical action and personality. Another part of the brain we need to talk about is within the midbrain, which is represented by that other little yellow blurb in the center. It's called the ventral tegmental area, which is kind of in charge of dictating your fight or flight response, your survival mode, and the things that you do when your life is on the line. Those two parts of the brain are very heavily interconnected with network of neurons that interact with each other depending on the level of dopamine, which is what is released in the nucleus accumbens that gives you pleasure, and the level of perceived threat to one's own safety. In addition, what happens is that the nucleus accumbens is overstimulated by a substance, such as opiates, to the point where dopamine is released way too heavily, more heavily than ever before, and it is categorized by the ventral tegmental area in the midbrain as a survival behavior. This leads the organism to behave as if opiate use was just as important for survival as breathing or eating or procreating. And because of that, the symptoms that are displayed by people who have opiate addiction is that they will do anything to continue that behavior pattern, even though it will be destroying them in the end. Next slide. Just for some perspective, here is a list of some other brain diseases. These are organic brain diseases: Parkinson's, migraine headaches, Alzheimer's, multiple sclerosis, epilepsy, and stroke. All of those are organic brain diseases that have a very direct effect on brain tissue. Addiction falls into this category of diseases. Next slide, please. As a reminder, over the last 20 years, opiate use in our nation has been rising at an alarming rate. You can see, unfortunately, you cannot see 2020, 21, and 22. Those are actually way higher. But this just kind of shows you that the overall trend is increasing. It is not decreasing. Next slide, please. In 2020, the American Society of Addiction Medicine came out with a national practice guideline for the treatment of opiate use disorder or opiate addiction. And in that practice guideline statement, they said, the combination of pharmacotherapy, which is medicines, and psychosocial treatments tailored to individuals' needs is the recommended standard of care. What they're saying is that the recommended standard of care is medications and psychotherapy or psychosocial treatments, not just the psychosocial treatments. Next slide, please. We are not going to go through each of these studies because we don't have time, but this is just a very small sample of some of the most important studies that have been published in the last 20 years that have corroborated and have made it very clear that the medications for treatment of opiate addiction are highly effective at saving lives and reducing the return rate to both use of opiates and recidivism to incarceration and return to treatment in residential and outpatient treatment programs. So the mounting body of evidence is absolutely unequivocal that medications for opiate use disorder is the recommended standard of care for patients who have opiate addiction. Next slide, please. We are going to talk specifically about the only 3 medications we have in our nation that are currently approved by the FDA for the treatment of opiate use disorder. There's a lot of stigma related to some of these medications. And there are so many people, both within the treatment community, the addiction treatment community, and those who are in the rest of the medical community, as well as in the civilian lay community, that believe that these medications are harmful. Often you'll hear things like, it's just trading one addiction for another. So why would you do that? That's harmful to people. Well, people can abuse these medications, and some of these medications do have an abuse potential. But the list of studies, like the one that I just showed to you on the last slide, have looked at all of those facets and have found that overwhelmingly prescribing these medications to patients saves lives and reduces treatment duration and treatment frequency. So it is tantamount to malpractice and medical neglect to refuse these medications to patients who have an opiate use disorder, who qualify for them and these medications are appropriate for them. They need to have a medical evaluation to determine which medications are most appropriate for them. But to refuse them on the basis that these things have an abuse potential is, to me, is ridiculous. So we're going to talk about each one of these medications, and then at the end, we're going to have some time for questions. Methadone is a full opiate agonist. We've talked about it a lot already. It was the first medication approved for opiate use disorder. It does have an abuse potential. It also has an additive potential, which means that if you add methadone, if you take your methadone and then you add oxycodone or you add morphine to it or fentanyl, those things combine to help you overdose. It does not have a ceiling effect, which means that your body can keep getting used to more and more and more. And as your dose gets higher and higher, the chance of overdose becomes even more likely. Methadone needs to be dosed daily. And initially, you have to go to a clinic every single day to get your dose. And over time, it is possible to work toward getting a take-home dose or 2 take-home doses, or even up to a month's worth of take-home, which is the maximum amount someone can get. It usually takes them 18 months of regular, consistent, and very, very good attendance and good compliance with their treatment program in order to get a month's worth of take-homes. That's about a typical time frame. And you cannot give methadone currently for opiate use disorder in any other venue. It has to be done at a certified opiate treatment program or methadone program. You cannot prescribe methadone for addiction at a clinic, an outpatient clinic, or anything like that. You can prescribe methadone for chronic pain with no restrictions, but that is becoming more and more frowned upon in the medical community. Next slide, please. Methadone is typically administered as a liquid. It can be given as a tablet in an opiate treatment program, but it's much easier to watch someone drink a liquid and make sure they have actually swallowed it before they move on. It's a little harder to cheek liquid than it is for a pill, so that's why it's done in a liquid. The most common side effects for this opiate are nausea, constipation, drowsiness, and decreased sexual function. There are some other side effects that tend to only come when a person has been on this medication for years, and those could be decreased bone mass and osteoporosis risk, hormone dysregulation like low testosterone, and a lot of problems with their dental hygiene. We've already talked about alternative use for methadone, and it is chronic pain. Next slide, please. The next medication we're going to talk about is buprenorphine. Buprenorphine is the active component or ingredient in medications like Suboxone or Subutex or Sublocade. Buprenorphine is a little bit different in that it is not an opiate, a full opiate. It is a partial opiate. And because of that, it tends to have a ceiling effect where once you give a certain amount, nothing above that will make much of a difference because the body is saturated already with buprenorphine in the receptors where they belong. It gives good pain control and it has a lower side effect profile than some of the other medications like all the other opiates. It also helps with depression. And the reason why a lot of people don't prescribe buprenorphine or haven't in the past traditionally is because if you give buprenorphine too early and there's another opiate in their system, it can precipitate a very, very bad withdrawal syndrome. So in order to keep that from happening, you have to prescribe buprenorphine after the other opiate, whatever it is, has cleared their system. Buprenorphine has a long half-life. It usually requires only daily dosing. And the withdrawal from buprenorphine is not as severe, though it does last longer. High receptor occupancy, which is the last bullet there, it's just another way of saying that it occupies receptors at a really fast rate. So low doses tend to yield high results. If you give someone 2 milligrams, you can get up to 30 to 40% of their receptors in their body filled, and that's a very low milligram dose. If you double that, you can get them to a higher dose. If you double it again to 16 milligrams, you're almost maxing out at about 95%. And doubling it again to 32 milligrams only gives you maybe a 1 to 2 percentage points increase. So that is the plateauing effect of once you get above 24 milligrams of Suboxone, it really doesn't do any more. It doesn't give any greater effect. Next slide, please. This is kind of a lot of pictures, sort of busy, but the point is there are a lot of products that have buprenorphine in them. And as time goes on, more and more products are available. You can get buprenorphine alone, and those are all those products that have only buprenorphine, or the second bullet has buprenorphine with naloxone, which is Narcan, mixed together to try to reduce the amount of illicit abuse of it. The regulation of a DEA X number or X waiver has historically been a big barrier to care. And a really incredible thing that just happened in December was that the federal law changed to where there is no need for any provider to have an X number or waiver in order to prescribe buprenorphine for opiate use disorder. In other words, they're counteracting the Harrison Narcotic Act with this medication, saying that any prescriber, that whether it's a nurse practitioner, PA, or doctor, can prescribe buprenorphine with no patient limits or regulations, as long as they are prescribing in other words, as long as they're using it medically as a best clinical practice. There is no cap of number of patients that need to be treated with it, or that can be treated with it, and there is no regulation of specific training in order to get a waiver or anything like that to prescribe. That is a change that recently happened. Buprenorphine is the best medication that exists to treat opiate withdrawals. Next slide. I'm going to take just a second and talk about a medication that has buprenorphine in it that is very, very helpful. It is called Sublocade. Sublocade is an extended release form of buprenorphine that provides blockade so that other opiates don't work, which is what buprenorphine does. It guarantees people cannot go off of their medications for about 60 to 90 days because it's injected under their skin. They can't abuse it, misuse it, or give it to someone else. And you only inject it once a month. It does hurt when it goes in, but it lasts for months and it protects patients against future opiate overdose. So it's kind of new on the scene. It was just approved in 2018 and started being prescribed in 2019, and insurances started covering it right around 2020, 2019. But this medication has really been a game changer for opiate use disorder because it prevents patients from doing what they stereotypically do, which is they stop their Suboxone and then they go and use. And with Sublocade, they cannot do that for sometimes 2 to 3 months. They would have to stop their injections for 2 to 3 months before they could possibly use. So it's been a really huge boon to the folks who really want to get better. And it's also created a lot of benefit for the medical community because we don't have to worry as much about, is this prescription going to get sold or misused in some way? It won't. So this is slowly kind of taking over the opiate use disorder scene in the sense of medical treatment. It's becoming more and more popular. Next slide, please. The most common side effects from buprenorphine are nausea. That is especially problematic with the sublingual formulation, the one that you put under your tongue, because it tastes horrible, and especially the one that has naloxone in it can create a lot of nausea. Because it does have activity at the opiate receptor, it can create constipation and sometimes some fatigue or drowsiness. But it is also a very good medication for chronic pain. And since it cannot basically overdose a person, because once you get above 24 milligrams, it does not really do much more, it's a much safer alternative. Next slide, please. We're going to talk about the third medication now for opiate use disorder, which is naltrexone. Naltrexone is an opiate antagonist, which basically means it's an opiate blocker, and it does not actually do anything with the receptor. It occupies the receptor, but does not turn it on. So it prevents opiate activity at that receptor. In order to take this, you have to be opiate free, meaning you don't have any opiates circulating in your bloodstream for at least 10 days to prevent what will certainly happen if you take this medication and get severe withdrawal symptoms that often require hospitalization. It comes in 2 formulations, a tablet that you can take once a day, or an injection called Vivitrol, which you take monthly. If you do have a patient on Vivitrol, they should have a medical alert bracelet, because if they end up in the hospital with any kind of injury or illness that's going to require surgery, it's going to create a very interesting problem for the people who are taking care of them, because none of the opiates they give them will work. Next slide, please. This is just a picture of the vials of Vivitrol and the kit that it comes in. Vivitrol is extended release, so you give it once a month. It guarantees that the patients will have no ability of using an opiate for about 30 days. So it provides complete blockade of all the opiates receptors. And you know that this is it's not a substance that has any type of reinforcing quality, so they will not want to use it illicitly. There's no street value for naltrexone. And so there's no risk of diversion or abuse. But the one thing to know about Vivitrol is, because it kind of resets their opiate tolerance, meaning it takes you to where you would be if you never tried opiates before. People who use Vivitrol and then they skip the next Vivitrol and they go out and use, if they relapse, their risk of overdose and death is much higher than if they never got on Vivitrol before. So Vivitrol is one that you have to enter. If you're going to use or prescribe, you have to do that with that full understanding that if the patients miss their next injection, they're at a much higher risk of death and of overdose than they would have been if you had used a different medication. Next slide. The most common side effects for naltrexone are nausea, diarrhea, headache, and withdrawals if you give it too early. And alternative use, naltrexone in a pill form can be used at very low doses that can sometimes help people with some chronic pain issues. It's not that great of a treatment and is not used very widely. But the way it is used is for alcohol use disorder. Naltrexone and Vivitrol shot in particular is highly effective at reducing alcohol use, alcohol cravings for patients who have alcohol addiction. Next slide, please. We are now at the point in the presentation where we can take questions.
I had a question, Dr. Bush. I'm wondering, was there any, as we were going through the history and we were talking about some of the different pharmaceutical companies that promoted use and things like that, was there ever any prosecution, financial ramifications, any sort of penalty that would dissuade another company from doing that again?
So Purdue Pharma actually recently, it was only a couple of years ago that they got prosecuted with a multi-billion-dollar lawsuit for their part in this. And mostly they were prosecuted for the deception that they they used in endorsing their product. There was a lot of stuff that happened that we obviously don't have time to go into today, but they were prosecuted. Another company that had a prosecution was actually Reckitt Benckiser, that was the company that made Suboxone, because of some of their practices and their marketing practices and things. So some of these companies are being prosecuted for shady practices, but there are many people in the medical community that do not believe they've been adequately held accountable, because, for example, OxyContin is still being sold by Purdue Pharma, and they're still making money off of this product. So it is definitely a good question, and there are still a lot of things. There's room for improvement. I think that holding these companies accountable for the risk that they, help these people basically take on. So hopefully that answers your question.
Yeah, one of the questions I had was, what are the typical age groups for when opioid addictions begin? Like, what are the modern demographics right now that we're looking at?
So that is a wonderful question, because it has been changing a little bit. It used to be that opiate addiction started in your late adolescence to early adulthood. And now what we're seeing is a trend downward toward younger and younger ages. So I would say that right now, the current most common age for people to be introduced to opiates is in their early teens. We've seen a lot of patients that have been introduced to opiates, recreational opiates, including heroin, under the age of 10. So it's an alarming trend that we're seeing, but it unfortunately most commonly experienced in the first half of the second decade. So like between the ages of 10 to 15.
So when you're treating opioid addiction as a brain disease, are there treatments that can be done that are in addition to pharmaceuticals? Other things?
Okay, so like procedures perhaps, or something like that is maybe what you're getting at. I'm not sure. But as we talked about with the national practice guideline that the American Society of Addiction Medicine produced in 2020, the standard of care is essentially pharmaceuticals plus psychotherapeutics. So those two are the main two categories that are used, but there are some interesting studies that are ongoing about things like acupuncture and alpha stim technology and other procedures. There just isn't enough evidence at this point to conclude that any of them are clinically effective at treating opiate use disorder. The two things we know are clinically effective are medications and psychotherapeutic modalities, such as CBT and DBT and motivational enhancement and things like that.
So so these new treatments that you've outlined, are they having an effect on the rates of addiction or overdose deaths, or is it just a little too soon to tell?
Currently, there hasn't been any large scale study that has shown anything, any procedural or interventional treatment that has actually reduced rates of overdose or reduced rates of addiction. Again, incarceration has long been held by some people as a treatment. We look at, if we just get them away from their opiate long enough, we'll just put them in prison. But we actually see jail does often prevent temporarily but not permanently. And then prison, actually, there's higher rates often of substance use in prisons. But none of these treatments like magnetic stimulation or alpha stimulation or EEG feedback or neurofeedback or biofeedback or acupuncture, none of them have been shown to be effective at this point. This is just a copy of some of the resources that I used to put together the slide, and that's pretty much all I have. Thanks for your attention.
Great. Well, thank you so much, Dr. Bush. This was so fascinating, and we appreciate your time and your effort, and we really hope that all of our participants have enjoyed the time with you. Thank you all for participating, and thank you so much for sharing with us again, Dr. Bush. For those of you who are exiting the portal at this time, please come back into the portal on time for your next session. You will need the unique password, your unique password to log back into the portal. So make sure you have that handy. Remember, if you want to earn CEUs for this session, please, you must complete the end of session survey, and it will prompt at the end of this session. Again, your keyword that you'll need to complete your quiz is strategic. Don't forget to take a moment and tour the exhibit fair. Our vendors and sponsors have some great resources and information for you. There are also opportunities for live chats at some booths. Also, the graduate student presentations are up and running. They have some wonderful research and information for you. They've worked hard to bring you that valuable information as well. And all of these things are available in the conference portal for you. Thank you again for joining us.